Hello everyone. How are you all? So today we will be doing part sixth of our revision, which includes infertility, genital infections, and all the estrogenic conditions. Okay. So all you are watching, please subscribe my channel, share it, so that all can get benefited. Okay. Our exams are very near. This means a lot to me, and this is only what I want from you. Okay, it will ease my teaching journey a lot. Okay, so once again, let's start our topic. Spermatogenesis. Infertility, we will be doing spermatogenesis. These days we are getting a lot and lot of question from spermatogenesis. So let's start it. Okay. So first of all, I want to tell you, as you all know that the oogenesis, it starts in the intrauterine life itself, whereas spermatogenesis, it starts at puberty. So first of all, you're going to clear yourself with this thing that that the spermatogenesis starts in puberty. Okay, once the puberty is achieved. So when FSH and LH are synthesized, the FSH, it acts on Sertoli cells, okay, and LH act on the Leydig cell. Okay, L for LH and L for Leydig. So the another one FSH is for the Sertoli cells. Okay, the Sertoli cells, they make sperms from the spermatogonia, and testosterone helps in this spermatogenesis. Okay, the Sertoli cells, they make sperms from the spermatogonia, and the testosterone helps in all this process. So this is how spermatogenesis occur. The time taken for the spermatogenesis is 70 to 74 days. Okay, these are the most important thing for your exam. Please don't miss not even a single word from this video. Okay. Okay. So this was a question asked in NEET PG. I was not able to trace the exact year and exact options, but this was asked. Okay. So what the options were: meiosis occurs at testes at puberty, repair and regeneration in testes in childhood, and ovaries at puberty. Okay. So this were the options. Somewhat the question was like that. So the answer to that question was testes at puberty, because you all know in the case of the oogenesis, this oogenesis has already started in the oogenesis has already been started in intrauterine life, and as far as the spermatogenesis is concerned, it starts only and only in puberty, whereas repair and regeneration, in the repair and regeneration of tissue, mitosis occur. There are two types of divisions, cell divisions. There are of two type, mitosis and meiosis. Okay, so in mitosis, basically the diploid cell, from one diploid cell, two diploid cells are formed, so chromosome number remains the same. In meiosis cell division, from one diploid cell, four haploid cells are formed. So the meiosis occurs only and only in the gonadal tissue, because in gonad tissue the gametes or sperms or ova are formed, which should be haploid. Okay, so this was one of the question which was asked previously. So now let's discuss the spermatogenesis. So first of all, in one exam in the last PYQ, it was also asked the order of this order of the cells in spermatogenesis. Okay, so you will remember here that the spermatogenesis start from spermatogonium. Okay, this spermatogonia is basically diploid, and this undergoes mitosis. Spermatogonia undergoes mitosis, as I already told you now only, that when mitosis will occur, then diploid cell will be formed. Okay, so primary spermatocyte is also diploid. Okay, then form and this primary spermatocyte, it undergoes meiosis 1. ठीक है, second, then form one primary spermatocyte, it from one primary spermatocyte, two secondary spermatocyte are formed, and meiosis 1 is after meiosis 1. Okay, meiosis has two phases, meiosis 1 and meiosis 2. The primary spermatocyte, which was diploid, now the secondary spermatocyte are formed, which is basically haploid. Okay, so this you should know, haploid. And now this secondary spermatocyte undergoes meiosis 2, meiosis 2, and then four spermatid are formed. From the two secondary spermatocyte, four spermatid are formed. So you can now here you can see that four spermatid are formed from one spermatogonia, and then this spermatozoa from the spermatozoa are formed due to maturation, and the spermatozoas are the sperms, which we say sperms, fully developed sperms, and these are haploid and they are very well structured. What is the difference between spermatid and spermatozoa? The spermatid is cell-like structure, whereas spermatozoa has proper sperm structures, acrosome on the cap and tail at the last. Okay, a proper acrosome, proper sperm structure. Okay, so this spermatid, they don't go under any cell division, they just undergo maturation, and that is how the spermatozoa is formed. Now here I would like to tell you, as the sperm grows, or as the sperm divide, or as a sperm formation is there, it proceeds in the genital seminiferous tubule. Okay, from the Sertoli cell they come out, and they then come in the lumen of the seminiferous tubule. This was asked in NEET PG 22. What is the order of the structure from adluminal to luminal? Adluminal means luminal के पास में, और luminal का मतलब है कि और inside the lumen, मतलब ल्यूमन के बिल्कुल बीच में. ठीक है, तो एज द स्पर्म ग्रोज इट प्रोसीड्स अहेड इन द जेनाइटल ट्रैक्ट. सो जस्ट नियर द ल्यूमन विल बी स्पर्मेटोगोनिया, देन प्राइमरी स्पर्मेटोसाइट, देन सेकेंडरी स्पर्मेटोसाइट, देन स्पर्मेटिड, एंड देन spermatozoa. So that is what all they have been asking continuously about spermatogenesis. So that is why I put this topic first before the infertility. Okay, so all the germ cells, whether it is oogonia or whether it is spermatogonia, all the germ cells, they arise from epiblast. Okay, all the germ cells, they arise from epiblast. Okay, I hope now there is no confusion in this. And this was about oogenesis. We have already discussed in the basic gynae lecture. Okay, those who have not watched, please go and watch that. That is also very, very important. Now I'm telling you, sperm attains motility. What do you mean by motility? Spermatid was changing into spermatozoa. So I told you that spermatid is basically a cellular structure, and then when it have its tail, its acrosomal cap, a proper sperm structure, so that is what it is. So sperm attains its motility in epididymis, especially in its caudal end. Okay, in the last end, tail end. Okay, so this is the question which can be asked, and it has been asked in the past also. Sperm attains motility in epididymis, especially in the caudal end. What is capacitation? Now after the sperm is released in the semen during the intercourse, now this sperm, it enters into the female genital tract, and then capacitation occurs. capacitation occur means the capacity of the sperm is increased. Capacity to fertilize is the capacity of the sperms to fertilize, it gets increased, and this is known as capacitation. What are the questions which are asked on it is where does the capacitation occurs? Capacitation occur in the female genital tract, and and you can tell that where in the female genital tract. Then the first answer which you are going to mark is fallopian tube, and the second answer which you are going to mark is cervix. Okay, now when sperm's capacity has increased in the female genital tract, now up to what time the sperm can fertilize the ovum, okay, is 48 to 72 hours lifespan of the sperm to fertilize, or you can say up till what time after its in whole capacity the sperm is going to wait for the ovum. After that the sperm will die off. The answer to that question is 48 to 72 hours. Okay, so each and every line again and again I'm telling you is very very important. So from now here we go to the next important topic, which is male infertility. Out of male infertility and female infertility, male infertility is very very important, so I have put it first before the female infertility. Let's start it. So what is infertility? Let's have first discuss that, because you all know that in FMG we get a lot and lot questions in FMG and NEET PG both. We get one question in exam on definition, so I always stress on definition. It's a straight way to grab that 1 marks in each subject. We get one question on definition, so please always focus on definitions, because definitions they clear the concept also, and definitions they get marks also. Okay, so what is infertility? If a couple is unable to conceive after 12 months of unprotected intercourse, then it is known as infertility. Okay, so male infertility, only one investigation is sufficient. Okay, if a couple comes with infertility, so you all know that male can be also the reason, and female can also be the factor of infertility. Is not only that always female is a factor, as it is think socially. Okay, so male can also be the reason, so only one investigation is sufficient. That is why we always, one whosoever comes with infertility, first of all we get the semen analysis done, because then it means on the male part there is no problem. Okay, these days lots of question are being asked on male infertility and on semen analysis and how to solve the male infertility, so please focus here. Okay, so in this semen analysis you should know whether the semen report is problematic, or it's normal, or it's abnormal. So what is the volume? I have chose only 4 parameters which can come in exam, so not 10 parameters, only 4 parameters, and this you should know by heart. First is volume. The volume of the semen should be more than 1.5 ml. Okay, to say it normal, it should be more than 1.5 ml. The sperm concentration should be more than 15 million per ml, and if they ask per ejaculate, then it should be more than 40 million per ejaculate. ओके, प्लीज सी लास्ट में क्या यूज किया हुआ है, पर ml यूज किया हुआ है या इजेक्यूलेट यूज किया हुआ है. अगर पर इजेक्यूलेट किया हुआ है देन द क्राइटेरिया इज मोर देन 40 मिलियन, एंड अगर स्पर्म कंसंट्रेशन यूज किया गया है तो मोर देन 15 मिलियन पर ml है. ठीक है, सो ये तो एक बात है. रिसेंटली WHO ने जो क्राइटेरिया दिया है वो 16 मिलियन का है, ये प्लीज़ नोट कर लेना आप लोग. ठीक है, मोटिलिटी ऑफ द स्पर्म जो है एटलीस्ट 40% ऑफ द स्पर्म्स शुड बी मोटाइल, एंड मॉर्फोलॉजी एटलीस्ट, मॉर्फोलॉजी मीन्स प्रॉपर एक्रोसोमल कैप है, प्रॉपर गोल्गी अपैरेटस है उसके हेड में, और टेल में प्रॉपर टेल है कि नहीं है, उसके सारे मतलब पार्ट्स फंक्शनल है कि नहीं है. मॉर्फोलॉजी इज मतलब जो एक प्रॉपर स्पर्म का स्ट्रक्चर होता है वैसा है कि नहीं है. सो एटलीस्ट 4% should be morphologically normal. Okay, so this is all you have to learn about the semen analysis. And if the count is less than 15 million per ml or 40 million per ejaculate, and it is known as oligospermia. Okay, and if the motility is less than 40%, then it is known as asthenozoospermia. Asthenozoospermia means, astheno means weak, it means they are not motile, means they are weak. Then it is if the structure is not normal, then we say it. If they are less than 4%, the morphology is abnormal, then we say it is teratozoospermia. Okay, it is teratozoospermia. Okay, so I think we are done with this now. Okay, so let's proceed. Now, a lot of questions are coming. You all know that they are coming on azoospermia. So let's discuss first its types. Okay, so azoospermia is of three types. Okay, you all are asking me in queries on Telegram. So just listen here. You will get a lot of knowledge here. See, what is pre-testicular? Pre-testicular means um, uh, before the testes. Pre means before the testes. Before the testes, as in females we have read very nicely HPO axis. In a similar way, there is hypothalamo pituitary testes axis in the male. So before the testes come hypothalamus and pituitary. So if there is fault or defect in the hypothalamus or pituitary, it is known as pretesticular azoospermia. Okay, because the hypothalamus and the pituitary, they are releasing gonadotropins FSH and LH. So this type of defect is also known as hypogonadotropic hypogonadism. Okay, hypogonadotropic hypogonadism. So this is in this, the FSH and LH, they both are decreased, as the name is telling, hypogonadotropic hypogonadism, because when they are decreased, we studied in starting only that this LH, they will act on the Leydig cells, and then the Leydig cells will release testosterone. Okay, now when the LH is not acting, then how the testosterone will be released? So testosterone is also less. Okay, so testosterone is also less. Okay, okay, so once again, in the pretesticular or hypogonadotropic hypogonadism azoospermia, the FSH, LH and testosterone all are less. Okay, next thing is, in what happens in testicular. Testicular means the fault is in the testes. It means the fault is in the testes. The FSH and LH, they increase and the testosterone is decreased. Why? Because there is a negative feedback of the, after a certain peak of the testosterone, there is a negative feedback of the testosterone on FSH and LH. Just as in ovarian failure, you know that FSH, LH increase and estrogen is decreased due to the negative, due to the absence of the negative feedback of the testosterone. In a similar way, due to the absence of testosterone, due to the testicular failure, there is no negative, there is no one to give negative feedback to FSH and LH. So FSH, LH increase. Okay, so FSH, LH increase. So here there is word no. So why FSH, LH increase? FSH, LH, they increase due to no negative feedback of testosterone. Okay, due to the no negative feedback of testosterone on, due to the no negative feedback of the testosterone, the FSH and LH, they increase and testosterone is decreased. In the case of the testicular failure, we always opt for biopsy. Okay, so recently it was asked in in this May exams, that one image of the biopsy was given, testicular biopsy. So that was Sertoli cell only syndrome. Okay. Now the third type is post testicular or obstructive. In this, FSH, LH, and testosterone all are normal, because the defect is not at the level of hypothalamus and pituitary. The defect is not at the level of the testicular. So FSH, LH is normal. The negative feedback is also going very nicely. So testosterone is also normal, but there is a obstruction defect. So post testicular means it is also known as the obstruction defect. Okay. In this post testicular or obstruction defect, we always go for ultrasound to find the defect, and this ultrasound is usually per rectal. Okay, and this ultrasound is usually per rectal. Okay, so once again I would like to tell you here that uh, in the case of the testicular failure, we opt for biopsy, and in the case of the obstructive or post testicular azoospermia, we opt for ultrasound, that also per rectal. Okay, obstructive zoospermia, it has the best prognosis. Okay, how it has a best prognosis? We have technique like TESA, MESA, PESA. What is TESA? TESA means TESA, testicular. Yes, testicular aspiration of uh, testicular sperm aspiration. ठीक है, testicular sperm aspiration. And PESA is percutaneous sperm aspiration. And next is MESA is microsurgical epididymal sperm aspiration. Okay, so in all of these, we in this obstructive oogospermia, where there is obstruction, just before that we will do the aspiration, and we will take out the sperm. Okay, out of this, MESA is the best, and most easy is the TESA. Okay, MESA is microsurgical, so it is the best, and TESA is the most commonly used in case of obstructive azoospermia, and obstructive azoospermia has the best diagnosis. Okay, just we have to, because there is obstruction, just before the obstruction, sperms are normal, we will take out the sperm and we will go for the ART, artificial reproductive technique. Okay, just before here, I would tell you about ART. There are two types of ART, IVF and ICSI. IUI is not a ART. ART का मतलब क्या है, उसकी डेफिनेशन क्या है? जब हम फर्टिलाइजेशन बाहर करते हैं, तो IUI में फर्टिलाइजेशन इज इनसाइड द यूट्रस, सो IUI इज नॉट अ ART. ओके, वी थिंक कि जो कुछ भी फर्टिलिटी क्लिनिक्स में हो रहा है वो सब कुछ ART है, नहीं है. ठीक है, जो सब कुछ भी होता है वो हमें लगता है कि वो ART है, वो नहीं है. ठीक है, सो IUI जो है, it is not a ART, yes, but it is a procedure which helps in fertilization. Okay, in conceiving. IVF में हम बाहर fertilization करते हैं, ICSI में भी हम बाहर fertilization करते हैं, तो both are you can say are ARTs. Okay, so IUI, when we do IUI, when there is oligozoospermia, so IUI is basically done at 10 to 15 million per ml. IUI is done. Basically, what we do in IUI, we wash the sperms, and we remove all the XYZ things, all the infections, all the antibiotics. We remove it and we put it in the uterus of the female directly. Okay, so that is IUI. What is IVF? In IVF, what we do, we give ovulation induction drug to the female. Female makes 10 to 15 ova, then we extract that ova per vaginally, then we take out the ova. Now here the green colored structures are ova. This you are saying these are all the tubes. Here this green color structures are ova, and then we put sperms in this test tube, and then they fertilize is in the test tube. Okay, so that is why it is known as the test tube baby, because fertilization occurs in the test tube. And for IVF, 5 to 10 million sperms are essential, and for ICSI less than 5 million sperms are okay. Okay, so now let's study that what is ICSI. What is ICSI? Let me tell you. In ICSI, what is happening? We take the site, we take the cell, ovum, we take the ovum in our lab, and then with the help of the injection we put one sperm inside. Okay, what is advantage by putting with injection? Why it is helpful? So here I would like to tell you one normal process which is occurring in human body. Whenever whenever spontaneous fertilization occurs, as it is happening in IVF, or as it happens in a normal female uterus, in fallopian tube, fertilization occurs in ampulla in the fallopian tube. So in a normal spontaneous fertilization without ICSI, this intracytoplasmic sperm injection, 1 lakh sperm, when 1 lakh sperm, they release their acrolysine enzyme, then one sperm enter. So one sperm, for the one sperm to enter, 1 lakh sperm acrosome, they release the enzyme acrolysine, then one sperm enters. ओके, सो दैट यू कैन से 1 लाख स्पर्म्स की बलिदानी चाहिए होती है उस एक स्पर्म को एंटर करने के लिए. सो इफ we want IVF, in IVF also spontaneous fertilization is occurring. All the sperms are the sperms, they are themselves entering. By ICSI we are inserting one sperm with injection. So if there is oligospermia or less than 5 million per ml, or very few sperm, 5-6 sperms only, then we will go for ICSI. Okay, and if the sperms are 5 to million per ml, then we will go for IVF. And if the sperms number is 10 to 5 million per ml, then we go for the IUI. Okay, so now when one sperm enters, we don't want polyspermia to many sperms to enter. Okay, don't we don't want many sperms to enter, so we want to prevent polyspermia. Polyspermia means that more than one sperm should not enter. As we have already discussed in molar pregnancy, if two sperm will enter, then molar pregnancy will occur. Do you remember? Right? So to prevent that polyspermia, there is a normal mechanism. There is a formation of zona pellucida or zona reaction around the oocyte. Okay, so there is a formation of zona pellucida, or we also say zona reaction occurs, and which prevent the other sperms to enter. Questions have been asked on this topic in the past, so please do focus. Okay, so morphology is so now you see in ICSI what we are doing, we are adding with the help of the injection, we are adding 1 to 2 sperm into the cytoplasm of the ovum. So if now this that 1 to 2 sperm is not having its proper nucleus, proper structure, then fertilization will not occur. Okay, so we have superimposed the problem of motility. We have we have solved the problem of motility, because if the sperm is not motile, then it's okay, we can insert it with injection in ICSI. ICSI is intracytoplasmic sperm injection. But if the sperm is not having a proper structure, then how fertilization will occur? Okay, sperm proper nucleus, sperm proper acrosome is needed for sperm proper nucleus is needed to fuse with the ovum nucleus, then only zygote will be formed. So morphology is the most important criteria. As if sperm has normal morphology, then the ICSI will be successful. Okay, but for ICSI to be successful, only and only we need morphology, normal morphology. Okay, if the sperm doesn't has motility, then it's okay. We can solve that motility problem by inserting the sperm with the help of injection. If there is oligospermia, then it's okay. We only need one or two sperms for ICSI. Okay, so all problems can be solved if the morphology is normal. But if morphology is not normal, if the nucleus is not normal, then how the abnormal nucleus will fuse with the ovum and uh, make the normal zygote. Okay, zygote will not be formed. Okay, so this was all about the male infertility, so you should remember it in detail. Okay, so now let's start female infertility. Female infertility is discussed here in very female infertility is discussed here in very in short, because it is not asked. Okay, so first of all, in the case of the female infertility, the problem can be at the level of three sides. It can be ovulation or ovary problem, it can be tubal problem, or it can be cervical factor. Sorry, it can be at four places. It can be at the ovary or ovulation, at the fallopian tube, or at the tubal factor, or at the uterus, or you can say endometrial problem with implantation, and the fourth is at the cervix level. Okay, so usually ovary and tubes are asked, and sometimes uterine factor is asked, so we are going to discuss only these three. Okay, so if first, one of the major problem, the most common problem which is responsible for infertility, for the female infertility, is the anovulation. Is the ovulation is not occurring. Okay, and most common cause for anovulation is PCOS. We will discuss tomorrow this PCOS. Now there is something known as ovarian reserve. We all know the females, they have their fixed number of reserve of oocytes or oogonia or follicles, that is known as ovarian reserve. What is ovarian reserve? The number of follicles or oocyte that the female is having in its ovary, that is known as ovarian reserve. Okay, these ovarian all these ovarian follicles, they mature uh, all these ovarian follicles, they mature uh, during the ovulation. Out of all this ovarian follicle, one ovarian follicle, it matures and ovulate, and then can fertilize if intercourse happened. Okay, so the number of the follicles which are there in the ovary is known as ovarian reserve. It can be tell by AMH. Lot of questions are coming on AMH. Don't miss any single point about AMH. Okay, so what is AMH full form? It is anti-Mullerian hormone. So more is the number of follicle, more is the AMH. So okay, more is the ovarian reserve. So AMH is directly proportional to the number of follicle. Okay, next question which they asked is a glyco on this factor also the question has come. Okay, to say that AMH is abnormal, to say that AMH is abnormal, To say that AMH is abnormal, the AMH should be at what level? So normal AMH is 2 to 5 nanogram per ml. To say it abnormal, it should be less than 1. You're not going to mark more values. Okay, if AMH is more, it means that it is more, ovarian reserve is more. If the AMH is less, it means ovarian reserve is less. The normal value is 2 to 5 nanogram per ml. Okay, a glyco, first, then another thing, it is a glycoprotein, it is not a lipoprotein. Okay, in the options they always put it is a lipoprotein. No, it is not a lipoprotein, it is a glycoprotein. Okay, and it is released by granulosa cell. So who is synthesizing this AMH? It is synthesized by granulosa cells. Okay, same those cells which were making estrogen, which were making inhibin B, all those same granulosa cells, they are making AMH. Okay, now not surprise, you all know that this AMH is formed in males right at the time of as their intrauterine life starts, right? Don't you know, in intrauterine life itself AMH is formed, right? Which does not let the Mullerian duct to grow in males, right? But in the case of females, this AMH is formed at puberty, and this AMH is formed at puberty, and this AMH, it decreases, mind my words, it decreases the sensitivity of the ovarian follicles to fertilize. Okay, it can be checked on, and the most good thing of this AMH is that we don't have to wait for day 2 and day 3. It can be checked on any day, okay, of the menstrual cycle. This factor that it can be checked on any time in any day. Okay, we have not to wait for day 2 or day 3 of the menstrual cycle. It can be checked on any day of the menstrual cycle. Along with this, the AMH also gives us the good report of the ovarian reserve. So AMH is the best test to see whether the ovarian reserve is good or not. Okay, will you remember it? Please don't forget this important points of AMH. This slide is very important. Okay. The other test which we can do for the ovarian reserve is the day 3 FSH. Okay, you all know in a menopausal lady FSH increase. When FSH increase, why the FSH increase? FSH increase because the estrogen, FSH increase because the follicles they are over in the menopause, right? The follicles, they get over in the menopause, they are finished in the menopause lady. So no estrogen is there. As no estrogen is formed due to the zero follicle status, so there is no one to give there is no negative feedback to FSH. So FSH and LH, they both increase. So more is the FSH, it means less are the follicles. So day 3 FSH is also a parameter for the ovarian reserve, but please, it is not as good as AMH. Okay, and only day 3 FSH is the parameter. The third is the antral follicular count on day 3 by ultrasound. Directly we measure how much are the for antral follicle. Antral follicle, I think you know that the antral follicle in the basic gynae we study the follicle in which there is a cavity is known as antral follicle. Once in FMG question has also come, they have shown a follicle with a cavity, so that is known, that was antral follicle. So antral follicle AFC on day 3 by ultrasound. So we count how many antral follicles are there on the day 3 by ultrasound. Okay, so these are the 3 tests. More are the antral follicle, more is the ovarian reserve. Okay, so these are all the three parameters which tell us ovarian reserve: AMH, day 3 FSH, and day 3 AFC. More is the AMH, more are the ovarian reserve, more is the AFC, antral follicular count, more is the ovarian reserve, but more is the FSH, less is the ovarian reserve. Out of this, best is AMH. No query in that. Now let us study the tubal factor. Okay, so you all know that when we are discussing tubal factor, the factors which affect the tube is PID, genital TB, and endometriosis, that we are going to study in the PID, genital TB soon. Just after few minutes we will study. Okay, now let us study the HSG. Okay, so HSG, what happens in HSG? So we do it in a pre-ovulatory phase, day 7 to day 10. Okay, day 7 to day 10, pre-ovulatory phase, we do this HSG. Okay, and laparoscopic hysteroscope. Sorry, let's first discuss the HSG. Okay, let's first discuss the HSG. So this HSG is done in the pre-ovulatory phase, just before the ovulation, and day 7 to day 10. Okay, some people do it day 4, day 5, day 6. Matlab before day 10 you can do it at any time, but because in the first 4 day menses are going, so it is better if you do it once the menses have gone. Okay, so this is a, you have to do it before day 10. Okay, pre-ovulatory phase before day 10. Okay, then next is endo. Yes, what we do basically in HSG, we instill a dye by Leach Wilkinson cannula. This was also a question in your FNG 22 exam. They have shown the Leach Wilkinson cannula. We have done many times in our um, telegram channel, those Leach Wilkinson cannula. Leach Wilkinson cannula, in when we instill the dye, we instill a radiographic dye from the cervix into the uterine cavity or endometrial cavity, and then we take x-ray images after instilling the dye via Leach Wilkinson cannula. Okay, now what does this HSG tell? This HSG, it tells us about the three things. Okay, this HSG, it tell us about three things. This HSG tells us about three things. One is that radiographic dye, when it is put in from the cervix, first of all it outlines the endometrial cavity and fallopian tube. So it tells us how is the shape of endometrial cavity. You know that we have done all those septate, biseptate, unicornuate, diadelphus, right? We have done all those HSGs. So it all outlines the endometrial cavity, and it also outlines the fallopian tube. If the dye spill is present in peritoneum, then tube. So now, if the dye has entered from the endometrial cavity to the fallopian tube, then it will go into the peritoneal cavity. If the spill is present in the peritoneal cavity, it means that the tubes are patent. So this HSG is done to see whether the tubes are patent or not. Okay, whether this is done to see whether the tubes are patent or not. Okay, 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 so that was about the HSG. Yes, now let's see what more I have to tell you is that you because HSG is not done in general anesthesia or GA, it is just underdone and under by sedatives. So patient suffers a lot of pain during HSG. So if excessive pain is suffered by the patient, then there is the bilateral corneal block on HSG, which is most commonly due to the physiological spasm. of the fallopian tube due to that excessive pain. So if there is a bilateral cornual block on HSG, we are not going to think that it is due to the, or it is due to the tubal blockage. It can be due to the physiological spasm of the fallopian tube. It means that just we have to go for the advanced test, which is laparoscopy, hysteroscopy, chemopertubation. Okay, so what is laparoscopy, hysteroscopy, chemopertubation? Yes, what is laparoscopic, hysteroscopy, chemopertubation? Here we put a laparoscope. Laparoscope we usually put in the peritoneum cavity. Okay, we put a scope in the peritoneum cavity. Now we have to distend the peritoneum cavity to see what is there in the peritoneum. So we distend the peritoneal cavity by CO2 gas, and that is what pneumoperitoneum is made. Please clear your concept. The pressure which is made while making the pneumoperitoneum is 10 to 15 mmHg. Please make क्लियर दिस कंसेप्ट. बहुत बार गलत कर चुके हो आप. प्लीज़ 10 से 15 करना है आपने इसको. ठीक है, ओके. सो 10 से 15 करना है आपने. ठीक है, 10 से 15 mmHg का प्रेशर होता है. ठीक है, और नीमोपैरिटोनियम हम जो है CO2 गैस से बनाते हैं. CO2 गैस हम डालते हैं पैरिटोनियम में, जिससे पैरिटोनियम डिस्टेंड हो जाता है. हमें सब कुछ बड़े आराम से दिख जाता है लेप्रोस्कोप से. CO2 ही क्यों यूज़ करते हैं? सबसे पहली बात, CO2 सस्ती है. नंबर 2, CO2 इज़ नॉट इन्फ्लेमेबल, मतलब आग नहीं पकड़ती है CO2, दैट्स वाई. Okay, this was it, why CO2 is used. Okay, then what is hysteroscopy? Hysteroscopy में हम एक स्कोप डालते हैं यूट्रस में, और हमें हिस्टेरोमिस यूट्रस, एंड हमें यूट्रस को भी डिस्टेंड करना होता है ताकि हम अच्छे से देख सकें, अपनी आंखों से इंटैक्ट देख सकें, लाइव देख सकें. सो उसको डिस्टेंड करने के लिए हमें लिक्विड मीडिया चाहिए होता है. ठीक है, अगर हमने लॉन्ग प्रोसीजर्स करने हैं तो हम जो है नॉर्मल सेलाइन यूज़ करते हैं मीडिया. ठीक है, और एक हिस्टोस्कोपिक मीडियाज़ पे प्लीज़ एक बार पढ़ लेना. ठीक है, अभी मुझे जल्दी जल्दी क्लास ख़त्म करनी है तो मैं यहीं इस टॉपिक को छोड़ रही हूँ. पढ़ लेना. बस इतना याद रख लो कि अगर हम लॉन्ग प्रोसीजर्स कर रहे हैं या बाइपोलर कॉटरी यूज़ कर रहे हैं तो हमने नॉर्मल सेलाइन यूज़ करना है. अगर हम यूनिपोलर कॉटरी यूज़ कर रहे हैं या छोटे प्रोसीजर्स कर रहे हैं तो हम ग्लाइसिन से भी कर सकते हैं. नॉर्मल सेलाइन जो है क्योंकि वो आइसोटोनिक होता है तो 2 लीटर तक एब्जॉर्ब हो जाए हमारी बॉडी में तो कोई प्रॉब्लम नहीं करता. पर ग्लाइसिन क्योंकि आइसोटोनिक नहीं होता, ठीक है, तो इसलिए उसको जो है 2 लीटर्स तक उसके एब्जॉर्ब होने का हम वेट नहीं कर सकते. ठीक है, सो ये हो गया हिस्ट्रोस्कोपी के बारे में. तो हिस्ट्रोस्कोप डाल के, डिस्टेंशन मीडिया डाल के लिक्विड मीडिया यूज़ करते हैं, नॉर्मल सेलाइन या फिर ग्लाइसिन. उससे हम यूट्रस को डिस्टेंड करते हैं और हम हिस्ट्रोस्कोप से यूट्रस को देखते हैं. सर्विक्स का यूट्रस का बाहर वाला सरफेस कभी नहीं दिखता. वेजाइना दिख जाता है, सर्विक्स दिख जाता है, एंडोमेट्रियल कैविटी दिख जाती है हिस्ट्रोस्कोपी से, लेकिन जो है यूट्रस का बाहर वाला सरफेस कभी नहीं दिखता. ठीक है, नंबर 1. नंबर 2 जो आपको बात याद रखनी है कि कीमोपर्ट्यूबेशन क्या होता है. बिल्कुल जैसे हमने अब, क्योंकि हिस्ट्रोस्कोपी लेप्रोस्कोपी हम GA में कर रहे हैं, साथ के साथ हम कीमोपर्ट्यूबेशन भी कर देते हैं. हम मिथिलिन ब्लू डाई डालते हैं, ठीक है, सर्विक्स के थ्रू, और उसको हम लेप्रोस्कोपिकली देखते हैं कि वो डाई बाहर आई कि नहीं आई, पेरिटोनियल कैविटी में आई कि नहीं आई. ठीक है, क्योंकि पेशेंट GA में होता है तो उसको कोई पेन नहीं होता और बड़े कंफर्टेबली पेशेंट हमें पता चल जाता है कि ट्यूबल ब्लॉकेज है कि नहीं है. लेकिन अगर कीमोपर्ट्यूबेशन पे ब्लॉकेज आई है तो इट मीन्स इट इज़ 100% कन्फर्म दैट ब्लॉकेज इज देयर. ठीक है, सो दैट वाज ऑल अबाउट फीमेल इनफर्टिलिटी. ओके, सो दिस वॉज द स्लाइड अबाउट हिस्ट्रोस्कोपी. ठीक है, आज हमने टेलीग्राम में और किया था जेनाइटल इन्फेक्शंस और पीआईडी. तो हेयर आई वुड लाइक टू टेल यू कि जेनाइटल इन्फेक्शंस पे ऑलरेडी एक वीडियो है जो मैंने टेलीग्राम पे भी पोस्ट की है. प्लीज़ उसको आप देख लेना. दैट वाज माय फर्स्ट वीडियो विच आई हैड मेड, और वो मैंने ऑलमोस्ट 1 वीक की मेहनत से बनाई थी. ठीक है. अब उसमें एक ही पॉइंट है इम्प्रूव करने वाला. जेनाइटल इन्फेक्शंस में एक ही पॉइंट है कि एंसेल क्राइटेरिया में बहुत बार पुरानी बुक्स ये देती हैं कि इंस्टेड ऑफ स्मेली विजाइनल डिस्चार्ज दे टेक पीएच, एल्कलाइन पीएच होना ज़रूरी होता है. ठीक है. सो यू आर गोइंग टू focus on this thing. Okay, now let's study PID and cervicitis. वो वहाँ नहीं है. ठीक है. सो PID जो है क्लेमाइडिया से मोस्ट कॉमनली होता है, और यूजली जो क्लेमाइडिया से PID होता है, मोस्ट कॉमनली क्लेमाइडिया से होता है, वो एसिम्टोमेटिक होता है. मोस्टली जो है क्लेमाइडियल PID ही होता है. ठीक है. और लॉन्ग स्टैंडिंग जो क्लेमाइडियल पीआईडी होता है, इट कॉजेज इनफर्टिलिटी. बिकॉज हम इसे ट्रीट नहीं कराते तो इट कॉजेज इनफर्टिलिटी. ठीक है. I think there is a emergency call. We will soon continue in the next video. Okay. So guys, all who you are watching, please subscribe and please like and share. Do comment whatever your problem is. I will solve. We are a very short family, and all these things means a lot to me, and that's the only gesture I want from you. Thank you.